From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at neighborhood-level social determinants of health and presenting characteristics for rhegmatogenous retinal detachments. And joining me is the corresponding author for this investigation, Dr. Cindy Kai. Dr. Kai is an assistant professor of ophthalmology at Johns Hopkins University School of Medicine. Cindy, thank you so much for joining us.
Neil, thanks so much for inviting me.
Maybe I could just dissect a little bit the title here, and you can help educate me. What are neighborhood-level social determinants of health?
Yeah, that's a great question. Social determinants of health are the conditions in which people live, play, and really just the conditions that set up daily living. And the reason we specified neighborhood-level social determinants of health was because we were looking at neighborhood characteristics. So, for example, the Area Deprivation Index is a measure on the block group level of, neighborhoods of about 600 to 3,000 people, and looked at characteristics such as home value, income, et cetera. So it's more of a composite measure of what's going on at the neighborhood level.
So maybe I could go on with the title and ask, what were the presenting characteristics that you were thinking about for a rhegmatogenous retinal detachment? What about its presentation were you specifically looking at?
Yeah, we were interested in whether or not the fovea was involved at the time of presentation for a rhegmatogenous retinal detachment, as well as what the visual acuity was. And specifically, we dichotomized it into vision better than 20/40 or worse than 20/40. And that's because, as a vitreoretinal surgeon, rhegmatogenous retinal detachments are the most common form of retinal detachments that we fix. And there are a lot of things that we can do surgically, but the most important predictors of vision outcomes after surgery are these presenting characteristics that we're looking at in this paper.
All right, so now I understand. You're going to look at these neighborhood level social determinants of health, and then you're going to see how they may or may not be associated with these very important presenting characteristics of rhegmatogenous retinal detachments because they are perhaps associated with the visual acuity outcome would be. Do I have that right now?
You got it.
Okay. So now, why were you pursuing this investigation? I mean, was it really important to investigate these specific determinants of health for how a rhegmatogenous retinal detachment may present itself?
Yeah, I think there are many determinants to look at. We were particularly interested in the neighborhood level ones because there's a lot of evidence now to suggest that the characteristics of where patients live. So, for example, this general socioeconomic deprivation of a neighborhood affect health behaviors and health outcomes. So, for example, among patients with diabetes, we've seen that patients who reside in neighborhoods with more socioeconomic disadvantage are less likely to get the recommended diabetic eye screening, and even those who do go to the eye doctor at least once are more likely to have a lapse in care and not return for follow-up. And so that's why we were interested in looking at the association of neighborhood level social determinants with these presenting characteristics in the context of rhegmatogenous retinal detachment as well.
And what neighborhoods did you look at? Was this throughout the United States? Was this in one region? Where were you doing this investigation?
We started with the patients who underwent primary repair of a retinal detachment at the Wilmer Eye Institute in Baltimore. So we took those patients and geocoded their address to match it to a census block group, and then gathered various neighborhood level characteristics about that particular neighborhood of where those patients were from.
And what are the methods that you might use to then try to match up these neighborhood level social determinants of health with the characteristics that the person may present with their retinal detachment?
So a lot of these neighborhood level social determinants of health are publicly available information. So the area deprivation index is freely available. And we also looked at other neighborhood level social determinants of various domains, for example, economic stability, education, access and quality, et cetera. And we obtained those from the American Community Survey as well as Policy Map, which is a mapping and analytics platform. And then the outcomes that we were interested in, these presenting characteristics that we obtained from the electronic health record at Wilmer.
And so the visual acuities, for example, are best corrected visual acuity on a electronic ETDRS chart, or are they just what the person's glasses are, or maybe a pinhole? What were those visual acuity outcomes that were, I guess you said 2040 was one of your dichotomous outcomes there?
We are limited because this was a retrospective study. So I would call these visual acuity measurements best recorded visual acuity, meaning if there were multiple values in the electronic health record with glasses and without glasses, we chose the better value. I would call that the best recorded visual acuity.
And about how many people is this that we're talking about that you looked at for these retinal detachments?
We identified about 700 patients who matched our inclusion and exclusion criteria over about a 10-year period.
And what were the neighborhoods they were from? Was it one or two? Was it quite varied? Can you give me a little feeling for what the characteristics were of these various neighborhoods that the people might come from?
Because Wilmer is a tertiary care referral center, I think we have a large catchment area. So the neighborhoods were quite varied. These patients were from at least 19 different states and a wide range of neighborhoods with different, for example, area deprivation indices.
So what did you find? Was there any relationship of these neighborhood level social determinants of health with those outcomes? Maybe we could start with whether the retinal detachment was fovea on or fovea off. Why don't we start there?
So we found that patients who resided in neighborhoods with more socioeconomic disadvantage, as indicated by higher values of the area deprivation index, had greater odds of presenting with fovea involving Rhegmatogenous retinal detachment. We also found the neighborhoods where a higher percentage of workers who drove to work were also more likely to have fovea involving Rhegmatogenous retinal detachments.
And what was the magnitude of that? How different were they, let's say, for the first variable that you were looking at?
First, the area deprivation index, we found there was about a 14% increase in the odds of having a fovea involving retinal detachment. And for the percentage of workers who drove to work, that was a smaller magnitude of difference, probably about closer to 1% to 2%.
And is that a big difference? Would we typically expect to see no differences if we were looking at perhaps characteristics that have nothing to do with it? Does this strongly suggest that there's some relationship there? Is it a weak suggestion? Give us an idea of what that 13% might mean.
Yeah, that's a great question. I would say it's not, it definitely is a statistically significant relationship on this. Probably not as strong as certain other determinants that we might look at. As with a lot of research projects, I think this is the beginning of further investigation looking into this topic. I think this project probably asks more questions than answers.
But at least you identified that there may be some relationship. Now, could you hypothesize why would that be? Why would there be differences in whether the person comes in with a retinal detachment that does or does not involve the fovea in that way?
Yeah, exactly. I think that's the ultimate question that we're trying to get at. So we know resources are not evenly distributed in this world, particularly healthcare. Rural places have a lower concentration of healthcare. And so one of the things that I have been wondering about is, are neighborhoods with more socioeconomic disadvantage just have a lower density of healthcare? So is it just that these patients have a harder time getting to the eye doctor. And even if they do get to a local eye doctor, they still ultimately have to be referred to a tertiary care center for the repair. So are we just seeing these patients much later in the disease process? So when their vision has dropped and when the fovea is already detached from the rhegmatogenous retinal detachment. So is that a possibility? And I think more investigation needs to happen to really look into that hypothesis.
And how about for the other outcome, determining what their visual acuity outcome would be? Did those have the same sort of factors that were associated with that, or you found different factors for that?
Those had similar factors. In addition to the area deprivation index and the percentage of workers who drove to work, we also found that a lower mean per capita income was also associated with presenting with vision worse than 20/40.
And I understand that you had this smaller, perhaps, magnitude of association when we're talking about whether there was a relationship to people who drove to work. Is that just because you looked at so many variables that maybe 1 in 20 might come up just by chance alone for these outcomes? Or do you think there's really some potential relationship? Is there a biologic rationale behind that one?
Yeah, it's certainly possible that this is coming up as statistically significant just based on chance alone. I mean, that's the whole point of the alpha type 1 error. We were hypothesizing that perhaps neighborhoods where a higher percentage of workers drove to work indicated some other aspect about the neighborhood. So, for example, perhaps we're looking at more rural areas where things are more spread apart. And so patients who do not have cars, for example, who live in these neighborhoods have a harder time getting to healthcare. But again, I think that's just a hypothesis. We have to do more work to investigate that.
And these are fascinating initial findings. Are there other reports in the literature that identified these for perhaps other ocular conditions? Let's say visions that people walk in with cataract or more advanced cataract or glaucoma? Or is this really the first time this sort of approach has been looked at for ophthalmic, let's say, urgent conditions?
This approach has been looked at in various diseases. The one that comes to mind at the moment is a group at the University of Michigan looked at various neighborhood level social determinants and presenting vision in the context of microbial keratitis. And I think their findings were similar in that they also identified that neighborhoods with more socioeconomic disadvantage, those patients tended to present with worse vision at the time of the initial diagnosis of microbial keratitis.
So that would be consistent then, perhaps across multiple ocular diseases. What are some of the limitations to this? I mean, I know we can't prove that if you have to drive to work, you are therefore going to walk in more likely with a greater chance of having your fovea off for retinal detachment. What can we say should be the next steps to try to figure out if this is, again, just due to other factors and the driving to work is just a confounder, or that it really is something to be considered and looked at in the future?
Yeah. As an immediate next step, I would love to see if our findings can be replicated using other data sources. Like I mentioned, we were just looking at patients who presented to the Wilmer Eye Institute. I would love to see if a similar study looking at, for example, source registry, which would include many academic institutions, or even the IRIS registry, which would capture the population seen by private practices in addition to academic medical centers, would have the same findings. And then ultimately, like you mentioned, I think we need to do more work to unearth the mechanism behind these associations.
And if you did find out that this was similar with other databases, what would you recommend for, let's say, public policies to be considered? I know that it wouldn't be definitive, but if you had the ability to make some recommendations if this was confirmed, what might some of those be to perhaps get these people in before the fovea has detached?
I still think it's early. I think more research needs to be done. But one of the things we could consider is using, for example, area deprivation index as a way to identify high-risk neighborhoods, initiate, for example, screening, or even more education or more availability of tertiary eye care, for example, retina specialists in particular neighborhoods.
Well, Dr. Cindy Kai, I want to thank you so much for sharing this information today. I think it's really groundbreaking to suggest that we may be able to use these methods to identify these higher risk individuals. And we thank you very much for investigating it and sharing it with JAMA Ophthalmology.
Thanks so much for the invite.
I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and I've been speaking with Dr. Cindy Kai about neighborhood-level social determinants of health and their association with the presenting characteristics for rhegmatogenous retinal detachments, finding that there are certain features that might be then associated with having a retinal detachment where the fovea is presenting on or off, and even some of the visual acuity outcomes. You can find a link to this article in the episode's description, and to follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.